what's issues important to patients, and this does include, as Pablo's highlighted, residual urine volume, critically important to quality of life, but also pruritus, as Dr. Supel spoke to, and other topics. By the way, the residual urine volume diuretic project was result of a competitive submission from our DOPPS Europe investigators for analytic projects of high importance. And we do have another call for such proposals coming up at this before the end of this year for next year. So we look forward to this. Well, we'll move on now to our peritoneal dialysis segment, PDOPPS, and the great fortune of working so closely with Jeff Pearl, who will be the moderator for this segment. Jeff is the principal investigator for PDOPPS and works at the University of Toronto and St. Michael's Hospital in Toronto. And Jeff is just an incredible leader in the clinical science of peritoneal dialysis, and perhaps even more important, a tremendous advocate for peritoneal dialysis and doing it right and doing in the right sorts of patients. So we're so fortunate to have Jeff working very, very closely with us. Jeff, take it away.
Thanks, Bruce, and hello, everybody. It's a pleasure to be speaking here today. And, you know, the irony here is we're all sort of doing this from home because of COVID-19. So there certainly have been benefits to receiving dialysis at home. And I'm so delighted to see peritoneal dialysis featured today as part of the DOPPS program of research. So this is a PDOPPS phase 2. These are our country participation, and we've had 236 sites with over 11,000 PD patients. And again, this is a real testament to all of our colleagues and friends around the world who have been able to collaborate and really do amazing work to get us to where we are. And in terms of the country investigators, this is our list of country investigators. And again, I just want to take this opportunity to thank everybody for all of their input and all of their leadership in the PDOPPS study. In terms of partners in research, similar to the other aspects of the DOPPS program, we've been developing data hubs, and there's 3 such data hubs in Toronto, in Australia, and in the United Kingdom, all doing analyses with the PDOPPS data, in addition to the wonderful analyses that are being done at Arbor Research. And there are also local study headquarters, including Chulalongkorn University in Thailand, led by our Thai investigators, and in South Korea. And we expect, you know, Thailand has been exceptionally productive in making the study relevant, and we look forward to continued output from South Korea. In terms of some ancillary studies, there's been several ancillary studies funded. You'll hear about our infection work in terms of the OPUS study coming up, and also studies looking at PD catheter function. So with that in mind, the PDOPPS session will first start off with insights into PD-related infections from the US and beyond. And it's a pleasure to introduce Eric Young, who's been working very closely with the US claims data to try and look at how to ascertain infection rates in the United States. And I'll be presenting some data from the PDOPPS study. Hello, everybody. It's a pleasure to present to you insights into peritoneal dialysis-related infection from the US and beyond. And I'm joined by Eric Young, who's a senior scientist at Arbor Research, and we'll be presenting you some of the latest information from our sub-study, Optimizing the Prevention of PD-Associated Peritonitis in the US. Next slide. So just want to remind everybody, our investigators in the OPUS study, and want to thank them for all of their participation. And it's been really fantastic to work with such amazing individuals. And support for this pilot study is provided by a grant from the AHRQ. Next slide. And so I just want to remind everybody what our study aims are for OPUS. One of our study aims is to develop a standardized definition for peritonitis and a protocol for peritonitis reporting. To use this definition to understand the variability in peritonitis rates and outcomes, to identify patient and facility characteristics that impact the risk of peritonitis, and clinical practices that impact the risk of peritonitis, and as well to work with knowledge users, including patients and providers, to understand how we carry out these aims and how do we knowledge translate these practices. Next slide. So in terms of one of our aims of standardized peritonitis reporting, next slide, we had applied the ISPD definition, and here's the ISPD definition for peritonitis: two of the following: abdominal pain or cloudy effluent, a cell count of greater than 100 with 50% neutrophils with a dwell time of at least 2 hours, and a positive culture. And taking that definition, next slide, and collected information, next slide, in a prospective way across sites in the US. And this was in response to a review that we did of the literature, suggesting that when we analyzed randomized controlled trials and other studies that had published information on peritonitis, different definitions of peritonitis were employed. Next slide. So using a standardized definition developed by our investigators and in collaboration with the definition from the ISPD, we are prospectively collecting information on at 62 study sites on 190 peritonitis episodes reported to date. And this is a one-year pilot to say, can we as a PD community and clinics come together to standardize and collect peritonitis in a standardized fashion? Next slide. This is the sites that are participating, and I want to thank all of the sites, including some of our dialysis organization partners, for participating in the pilot study. Next slide. And these are our key findings. You can see here, at least when we submitted this data to the ASN, we've had 86 peritonitis episodes. And one thing, just to provide some insights in terms of tracking peritonitis in a standardized way, is a very high rate of culture negative. And you can see here, 21 cases of the 86 were culture negative peritonitis, suggesting that this is a larger challenge than we previously thought. And as the study comes to the end, we'll be sharing more insights about what we found in the tracker pilot study. Next slide. Looking at the PDOPPS data and what we've learned about peritonitis rates, practices, and outcomes. Next slide. We've learned that there's huge variability in peritonitis rates across the world, and even within clinics, there's significant variability in peritonitis rates. And in the PDOPPS data, there was an overall peritonitis rate of around 0.28 episodes per patient year. Next slide. One of the things that we've also learned is that uptake of evidence-based practices is quite poor in some countries. In the US, for example, only 63% of medical directors endorsed using antibiotics at the time of PD catheter insertion, which is a grade 1A ISPD recommendation. Next slide. Next slide. And so when we looked at the risk factors and factors that were associated with a lower risk of peritonitis, you can see here using antibiotics at catheter insertion was associated with a 20% reduction in the risk of peritonitis. And that might be the practice itself, but it also might mean that clinics that adhere to evidence-based practices may do so in other realms of peritonitis prevention. Interestingly, we also found that greater use of APD was associated with a lower risk of peritonitis. Next slide. One other important point that has come through is that culture negative peritonitis was a major challenge, both in our tracker study, as we showed you, and also in PDOPPS. Next slide. And we understand that according to ISPD guidelines, less than 15% of episodes should be culture negative. And there are ways to reduce that in terms of how the effluent is handled. Next slide. When we look at our culture negative peritonitis rate, you can see that it was well above the ISPD recommendations in many countries and ranged between 14 to 28%. It was particularly high in Thailand. Next slide. And if we look at the impact of different organisms on outcomes of peritonitis, and this is a composite of catheter removal, death, transfer to hemodialysis, you can see here that culture negative peritonitis tends to be associated with a lower cure rate compared to gram-positive peritonitis as the reference group. Next slide. Next slide. Oh, and so in this quality improvement project within Thailand, they noticed this as well. And they sent samples not only to a local lab for analysis, but also sent samples to a central lab as a quality improvement project to reduce culture negative peritonitis. Next slide. And what you can see here is that what the central lab, if we go back, grew many more organisms than were grown locally, suggesting that locally, microbiology labs in Thailand may not be adhering to best practices when it comes to optimal culturing of the effluent. because the central lab using ISPD endorsed practices did yield more organisms than was at the local lab, which reduced the risk of culture negative peritonitis. So a really important quality improvement project. Next slide. If we look at hypokalemia, one of the papers that was published in our experience was the relationship between low potassium and peritonitis. And there is a relationship, but once we adjust for patient characteristics, including nutritional factors, that attenuates the relationship. So in part, the relationship between low potassium and peritonitis may be mediated by markers of nutrition that may track with a heightened risk of peritonitis. Next slide. If we look at peritonitis and infection, it's the leading cause of transfer to hemodialysis across all countries in the PDOPPS, suggesting that we need to develop strategies to prevent it. And once peritonitis has developed, we need to develop strategies to reduce the risk that it leads to an adverse event. Next slide. And so when we look at those adverse outcomes following a peritonitis, you can see here, this is the distribution of deaths, hemodialysis transfer, catheter removal, and relapse and recurrent peritonitis, which are all adverse events following a peritonitis. And you can see the distribution of these across countries with some subtle differences between the countries. Next slide. When we looked at the cure rate by country, which was a composite of not having a relapse or recurrence, not having the catheter removed, not transferring to hemodialysis, and not having a mortality event following peritonitis, we can see that there is variability within countries, and again, some subtle differences with cure rates across countries. Next slide. Pointing back at this graph, you can see that not only was culture negative peritonitis associated with a lower rate of cure, but gram negative, typically bowel bug peritonitis, was associated with a lower risk of cure compared to gram positive peritonitis, suggesting that these might be very difficult infections that we need to improve cure rates from to reduce adverse events following a peritonitis event. Next slide. One of the interesting findings here was that when centers were using an aminoglycoside or ciprofloxacin-based empiric gram-negative antimicrobial as their empiric therapy for peritonitis treatment, there was a much higher rate of cure. And perhaps it relates to emerging resistance with cephalosporins or higher antibiotic levels with the uses of aminoglycoside and ciprofloxacin that made these potentially superior in terms of resolution of gram-negative peritonitis. An important finding in PDOPPS that needs to be confirmed in other studies. Next slide.
I'm going to talk about using Medicare claims to understand PD infection rates, outcomes, risk factors, and modifiable practices in the US, or at least some of those topics. Next slide, please. By way of background, peritonitis is obviously an important problem, as Jeff has illustrated. And prior studies, many of them may have a relatively small or non-representative sample. And as we've heard, there are sometimes variable definitions applied to defining peritonitis. And so we thought that Medicare claims might provide a unique population-based perspective featuring large sample size, a more representative sample, and that it has thus far been an unexploited opportunity for studying PD-associated peritonitis. So we use the USRDS standard analysis claims files from 2013 to 2017. These are files with inpatient, outpatient, and physician supplier claims. We identified those ICD-9 and 10 codes that were used to identify peritonitis. We reasoned that closely spaced claims were considered part of the same peritonitis episode, and we defined a new episode to occur when there was a new claim that was greater than 30 days from any prior peritonitis claim, or more than 50 days from the initial peritonitis claim, in the absence of any other claims in the 10 days before that time point. Next slide, please. So this just shows the variability in diagnosis codes, you can see that we had in the range of 70 to 80,000 claims per year. So overall, we analyzed over 375,000 claims. We identified 28 ICD-9 and 10 codes. We switched from ICD-9 to ICD-10 in this time period. We identified 28 codes that seem to indicate peritonitis. Rather than showing all 28 of them, I'm just showing the categories that we identified. The first one is our codes that we call acute peritonitis codes that simply indicate peritonitis in some sense. There were 9 such codes, and they account for the majority of claims, 71% in 2013 down to 61% in 2017. Over all years, they accounted for 65% of claims. So this is the biggest category, although as you can see, it is declining over time. Then we identified 2 codes that indicated spontaneous bacterial peritonitis. These codes are usually used for patients with liver disease and ascites and are probably not necessarily appropriate for patients with PD-associated peritonitis. Nonetheless, they are used about 3 to 6% of the time, 5% overall, and we think they actually indicate PD-associated peritonitis. We identified 13 codes that we called complication codes, usually due to a perforated viscus, appendicitis, intestinal perforation, something of that sort. Those accounted for about 2% of claims. And then finally, there were 4 codes that we've called catheter codes. These signify inflammation or infection of the catheter and or peritoneum. And it's a little ambiguous as to whether these codes are for exit site infections or for peritonitis. We actually think they are used to indicate both diagnoses. These codes are used 28% of the time, and their use is actually increasing over time. So overall, these claim codes we applied our rules, our timing rules, and they yielded over 70,000 episodes. There was a mean of 5.6 claims and a median of 2 claims per episode. 40% were exclusively outpatient, 9% were exclusively inpatient, and 16% were exclusively based on catheter code claims. Next slide, please. And this shows the rates that we found. So we had a reference set of rules that I've partly described. And using these rules, we found an overall rate of 0.54 episodes per patient year, with actually a decline from 0.61 in 2013 and a steady decline to 0.49 in 2017. So it was falling by about 5% per year. Now, our sensitivity analyses looked at other ways of defining peritonitis. We've done several such analyses. In one, we excluded the use of catheter codes altogether. Remember, this is that ambiguous category where we're not sure if it's indicating an exit site infection or peritonitis. When we exclude these codes, we find an overall rate of 0.45 episodes per patient year. And then when we restrict episodes to those where there's at least one claim that was submitted by a dialysis facility or a nephrologist, we find a rate of 0.35 episodes per patient year. And this gets us more in the realm of what is reported in dialysis facilities and what Jeff reported for the PDOPPS study. And it suggests that clinic reported rates may have an issue, and that the clinic may not be aware of all the episodes of peritonitis that may happen in hospital settings or outpatient settings where the dialysis facility may not be involved. That's a hypothesis that needs to be explored further. Next slide, please. And we found that peritonitis rates varied by year, as I've said, and by patient characteristics. So here's a couple of graphics that show peritonitis rates on the y-axis and year on the x-axis. The panels on the left show the impact of various demographics. First, you can see age, that younger patients tend to have a higher peritonitis rate in any given year. You can see there's a significant race effect, such that Black patients have a higher peritonitis rate than white patients, and Asian patients have a lower peritonitis rate. You can see there's a vintage effect. In these crude unadjusted analyses, patients with longer vintage have a higher risk of peritonitis. And then finally, there's an impact of ESKD cause, such that diabetic patients tend to have higher peritonitis rates. Now on the right, we show the impact of prior peritonitis episodes. And when there's no prior peritonitis episodes, the peritonitis rate is in the range that we've talked about. But with each increment increase in the number of prior peritonitis episodes, there's a very large, substantial increase in peritonitis risk. You can see the impact of 1, 2, 3, and greater than 4 prior episodes of peritonitis. So that's an important risk factor. The next slide shows a multivariate Poisson model of peritonitis risk, where we combine these various factors. And I'm just going to show selected factors that were in the model. We actually did 2 models, Model 1 and Model 2. Model 1 has patient demographics without including the number of prior peritonitis episodes. And you could see the age effect that I talked about, younger patients having a higher rate. You can see the race effect, higher rates in Black patients, lower rates in Asian patients. You can see the cause of ESKD impact, diabetes, and to some extent hypertension having a higher risk, and the vintage effect, or time with ESRD, risk going up with higher vintage. But in Model 2, where we also include the number of prior peritonitis episodes, you see similar age, race, and cause effects, but the vintage effect changes. It turns out the higher vintage patients also are more likely to have prior episodes. So when you account for that, which is again a very big effect, you can see that the vintage effect goes away, and in fact the higher risk is associated with patients with a lower vintage. So there's a really dramatic interaction between vintage and prior peritonitis episodes, as illustrated in this multivariate analysis. Next slide, please. So to summarize our initial work on using claims, we found considerable coding heterogeneity that we think indicates a lack of standardization among providers. And there is a need for clearer coding guidance so that we have more consistency in use of diagnosis codes. We found that peritonitis rates varied from 0.35 to 0.54 episodes per patient year, depending on the rules used to derive episodes from claims. And these rates are a little bit higher than what is often reported by dialysis facilities and other studies. We found that peritonitis rates declined by about 5% per year between 2013 and 2017. We identified some initial risk factors. There are more to explore, but in our initial analyses, we found an impact of age, race, diabetes, and prior peritonitis. And overall, the findings raise important opportunities that we hope to explore, including reconciling these findings with clinic-based measures of peritonitis rates. We want to promote uniform coding standards. We think there should be some discussion of modernization of diagnosis coding to capture all the aspects of PD-associated infections in a better way. And we think that this approach will lead to help with efforts for targeted practice improvements. And we do think that this claims-based approach offers a robust framework for the study of PD-associated peritonitis. Thank you.
Thank you, Eric. So some insights from CMS claims data, some insights from the PDOPPS international study, and some insights from tracking peritonitis across facilities with a standardized approach. Thank you for your attention, and so look forward to questions. Thank you. Our next presentation will be regarding a new initiative with PDOPPS, the DOPPS Practice Monitor with insights into real-time PD care, presented from Jenny Shen, Assistant Professor of Medicine at UCLA Harbor.
Hello, my name is Jenny Shen, and today I'm here to talk about the DPM Goes Home, insights into real-time PD care. A little bit of background, there are 780,000 individuals in the US who receive dialysis or have a kidney transplant, with nearly 60,000 patients dialyzing at home with PD. The PD population is expected to increase, so it's important to know what clinical practice trends are looking at. In terms of the DPM PD, it is the DOPPS Practice Monitor Peritoneal Dialysis, and it's a web-based report of up-to-date trends in clinical care of US PD patients. The reports include clinical practice and PD prescription data with more than 150 charts, figures, and data tables. This data comes from the PDOPPS study, which includes 150 US dialysis PD facilities that together contribute data on over 4,000 PD patients. We should note that facilities in PDOPPS have to have at least 20 PD patients, so it may not be reflective of trends in smaller dialysis units. The DPM PD data are updated every 6 months to reflect the most recent changes in clinical PD practices, which may be due to payment or policy updates, availability of new products, or other reasons. And to access it, you can visit this website, www.dopps.org/DPM-PD. When you click on that link, you're going to come to this webpage, and it'll show DOPPS Practice Monitor Peritoneal Dialysis, and up here it should say PD. This is actually a drop-down menu, and you'll see that you can also pick HD because there's also a DPM HD that's been around for some time. You can play with that drop-down menu, and you can compare the data between the PD and the HD populations. If you look on this first tab here, Browse All Data, the first thing you'll have to choose is if you want to filter by clinical topic, and in future iterations, you can also filter by facility or patient characteristics. You then choose a category, and these are the categories that are available: demographics, nutrition, diabetes, cardiovascular, PD prescription, anemia, PD urea clearance, potassium, residual kidney function, and mineral and bone disorder. If you click on this tab on the far right, on About PDPM, it reviews the data that we talked about before in terms of the PDOPPS study and where the data are coming from. Now we go back to this first tab and browse all data, and you filter by clinical topic. And let's say you decide to choose demographics. You'll see there's a number of different graphics that are going to come up under demographics. And the first one of these is age and categories, looking at the national sample. So what this means is you look at all the different time periods from April 2019 to August 2020, and it'll tell you the distribution of age of the patients who were in the PDOPPS study at that time. So you can see here that over time, from April 2019 to August 2020, that the average age of PD patients may have gone down somewhat, because you look up here in the dark blue, this is the percentage of patients who are at least 75 years old, and that has seemed to shrink a little bit over time. Now, in future iterations, you will be able to stratify by facility size, Black race, and time on PD as well. So for example, you could look at the distribution of age of patients by race. Now, going back to demographics, if you want to take a look at the race of PD patients in PDOPPS over this time, you can see that it stayed pretty much steady here. About 25% of patients on PD have been Black. Now, if you compare that to the DPM HD or hemodialysis, you can see that the percentage of patients who are Black in hemodialysis is far higher, excuse me. So you can see here that there's fewer Black patients who are on PD. In terms of diabetes as a cause of ESRD, you can see here that maybe about 45% of PD patients report diabetes as a cause of their ESRD. Now you compare that to the hemodialysis data. In the hemodialysis population, there's a higher percentage of patients who have diabetes as a cause of ESRD. So the prevalence of diabetes as a cause of ESRD is definitely lower among patients on PD than among HD in the DOPPS studies. If we look at time with end-stage kidney disease, again, we see that over time, as PD has gotten more popular, the time on ESKD has slightly shifted down. So if you see here in the light blue, this is the percentage of patients who have been on end-stage kidney disease, have had end-stage kidney disease for only about 0 to 3 months, and has actually gone up over time. So this might represent more incident patients starting on PD. As we look at some trends now in mineral bone disorder, we'll start with PTH. You can see that the distribution of lab values hasn't really changed a whole lot over time. It's fluctuated a little bit, but it is notable that overall, about 20% of patients have a PTH that's more than 600. And similarly, if you look at serum phosphorus, again, the distribution of labs hasn't really changed a whole lot over time. But you can see that about 15% of patients have a phos above 7, which is pretty high. In terms of anemia, if we look at hemoglobin here, again, the general trends in the lab values hasn't changed a lot. You have about 20% of patients who have a hemoglobin below 10, and about 20% of patients who've got a hemoglobin above 12 here. Now, we take a deeper dive into the anemia data. You can actually take a look at trends in ESA use. It hasn't really changed very much, and the EPO use in PD patients, I would note, is lower than it is among hemodialysis patients. Now, as we look at ferritin here, the ferritins have slightly trended up. So if you look here in the green, these are the patients who have a ferritin that is at least 1200, quite high. And you can see that it's now about 20% of patients who have that very high ferritin. On the other hand, if you look at transferrin saturation, the TSATs, if you look here, the percentage of patients who have a TSAT less than 20% may have gone up a little bit over time. And finally, if you're looking at IV iron use, it's gone up a little bit, but then has come down slightly as well. So the IV iron use has gone up and down, hasn't really mirrored the trends in ferritin or TSAT. And finally, if you look at PD modality, you can see that CAPD here in the blue has tended to go down over time here. So thanks again for letting me introduce the DPM PD. We hope you all have a chance to look at it and use it. It really gives a unique opportunity to look at some real-time data that's not available elsewhere. And this will shed insight into how clinical practice in PD is evolving. Thank you very much.
Thank you, Dr. Shen. And I just want to remind everybody, we'll do our best to answer all the questions in the chat. And as always, feel free to reach out to us after. We were not going to have time for a live Q&A, but really want to make sure we answer your questions. And our last presentation will be by Dr. Marc Lopez, who will talk about association of markers of mineral and bone disease with adverse outcomes in patients on PD.
This is Marc Lopez. I'm an analyst at the DOPPS study, and it's my pleasure to be here at the DOPPS Autumn Update Meeting 2021. And today I'll talk about mineral and bone disease in patients on peritoneal dialysis. So there's a PDOPPS study, and it's titled An International Comparison of PTH and Serum Calcium Control and Associated Outcomes Among Patients on Peritoneal Dialysis in PDOPPS. Although we know that for patients that are on hemodialysis, that out of range levels of PTH and calcium are associated with worse outcomes, we don't know that for sure for patients on peritoneal dialysis. We have previously shown an analysis using PDOPPS data that phosphorus, which is another mineral and bone disease marker, is associated with adverse outcomes, especially cardiovascular outcomes, the MACE, major adverse cardiovascular events. We don't know that PTH and calcium have this association. Recently, a study showed that PTH levels, especially low PTH, is associated with peritonitis. But for other adverse events, this association has not been clear. So this analysis has the following objectives: describe baseline serum PTH and calcium levels across PDOPPS participating countries from the years 2014 through 2021. And we also want to test the association of baseline PTH with all-cause mortality and the major adverse cardiovascular events, MACE. So for this analysis, we included patients that were on PD from Japan, Australia, New Zealand, Canada, Thailand, the UK, and the US from phases 1 and 2 of PDOPPS, and South Korea from phase 2 only. The 6,473 patients, they had to have at least 6 months of treatment, of peritoneal dialysis treatment, since we expected that in the beginning of, as they start on that therapy, there need to be some adjustments for MBD medication, and so we thought that this could confound the results a bit. So we prefer to exclude these incidents, very early incident patients. We also excluded patients that were hybrid. They will be on PD and HD at the same time. And for the MACE analysis, we only included patients that came from facilities that had good reporting of causes of death and hospitalizations, and also collected PTH regularly. Our primary exposure was the PTH level, most recent in relationship to the baseline. Primary outcomes was all-cause mortality and also MACE, which is a combination of cardiovascular mortality and hospitalizations for stroke, unstable angina, myocardial infarction, and heart failure. We censored patients that transferred to hybrid therapy or hemodialysis, transferred to a new facility, were transplanted, or were followed up until the study end. Here we describe patient characteristics based on categories of PTH levels. There are some things to point out in this table here. First of all, most of the patients are within the range of 150 through less than 600 picograms per ml of PTH. The patients that are on the high end of PTH levels, so greater or equal to 800, they are on average 10 years younger than those with the less than 50 picograms per ml of PTH. Black patients are more likely to have high PTH, so they are 4 times more likely to be on the 800, greater or equal to 800 group than the less than 50 group. And patients also have more time since they started PD in the low PTH group. So the low PTH group have patients that have been on PD for more time than the other PTH categories. In terms of dialysis prescription, I want to point out that for the patients with the low PTH levels, so the less than 50 group, they have a much greater proportion of patients that were prescribed a high dialysate calcium. So dialysate calcium greater or equal to 3.5 milliequivalents per liter. In this group, they were 3 times as likely to have this high dialysate calcium compared to the greater than 600 PTH group. In terms of country variation of the PTH levels, a few things are worth pointing out. In Japan, patients with lower categories presented with a higher proportion there compared to all other countries. The high PTH levels, they were pretty similar in the US, Thailand, and Canada, much lower in Japan. In terms of serum calcium variation across countries, a few things are also worth pointing out. Most of the patients were in the normal range. In the Asian countries, Japan, South Korea, and Thailand, there was a greater proportion of the patients with lower the 8.5 serum calcium levels compared to all other countries. In this table, we show the association of baseline PTH with all-cause mortality by level of adjustment. So in Model 1, it's basically stratified by country and study phase. Model 2, we add demographic variables, age, race, and sex, comorbidities. In Model 3, we add to Model 2, the residual kidney function, PD mortality, and PD volume. So basically, for PTH and all-cause mortality, we don't see an association, neither in the unadjusted model all the way up to a model with all covariates. In this table, we show the association of baseline PTH with MACE, so major adverse cardiovascular events. Already in Model 1, where we just stratify by country and phase, you can see that there is an association with low PTH levels, and it gets stronger as we add covariates in the model. There are no clear associations with the high PTH categories with MACE, although also this association gets stronger as we adjust. So in conclusion, patients on PD with low PTH levels, meaning less than 50 picograms per ml, they have a higher rate of major adverse cardiovascular events. As you saw, the association gets stronger as we add more confounders in the model. For the high PTH levels, we did not see that association, although as we add more confounders to the model, the effect estimates get stronger, so there could be possible unmeasured confounders. There was no association of PTH levels with death. So for the all-cause mortality, no association was seen even with adjustments. Some PTH variation is seen across DOPPS participating countries. Japan has more patients with lower PTH levels. Black race is associated with high PTH levels. So they are 4 times more likely to be on the greater or equal than 800 picograms per ml than the low less than 50 group. Patients with lower PTH levels, they have a larger proportion of high calcium dialysis prescriptions. So even though they are on the low end of the PTH levels, so less than 50, they have a much greater proportion of patients that are prescribed high calcium dialysis compared to the other PTH groups. Also for this group, less than 50, they have a higher PD vintage, meaning they started therapy before all other categories of PTH. Due to the study design, we cannot exclude unmeasured confounding and also other scenarios that are associated with the observational nature of the study design. So this study calls for further investigation with more appropriate design to investigate this question. Thank you for the opportunity, and I look forward to hearing your questions.
Thank you. Thank you, Marcello, for a really interesting session, and leaves us with a lot of questions. And what a great way to end the PDOPPS session with some really interesting findings. Turning it over to you, Bruce, and thanks for listening to the PD portion of the Autumn Update meeting.
Jeff, thanks so much. Fantastic. And I think this just illustrates the importance of bringing these data to the fore, right? They're really doing very serious data collection and analysis with the large enough samples of PD patients, and we have much more to learn, of course. Jeff and speakers, thank you all very, very much, and we'll move on now to